here. We're going to take a couple minutes just to let a few late stragglers get registered and sign in, and then we'll be beginning the presentation. There's quite a bit of information that we're going to go over today. It's quite a dense presentation, so I want everyone to know that this will be posted on the website at NAAOP.org starting tomorrow. And hopefully this can be used as a resource that you can go back to and reference later on when you're kind of facing some of the challenges that we'll address. Okay, we'll go ahead and get started now. Thanks for coming, everybody. Today's session is titled How to Implement Recent Policy Wins in Clinical Practice. I'm Nathan Capa, the president of NAAOP, and today I'm joined by Peter Thomas, our general counsel, and our executive director, George Brees. I'd like to begin by saying thank you to George for 38 years of dedication to NAAOP and the orthotics and prosthetics profession. For anyone who's not aware, George has announced that he plans to retire at the end of 2025. As he moves into the next phase of his life, he leaves behind an imprint that shows a lasting legacy of caring for those with limb loss and limb difference, along with the providers who care for them. With that said, I'll pass the mic to George for a message on behalf of NAAOP.
Well, thank you for being with us today, and thank you, Nate, and especially want to also thank Peter, all the good folks at Powers, Michael and Leela and all of them, and of course, thank Paul Pruzakowski and Kara for all of their efforts in helping us with this webinar. I would like to say to those that you are members of NAAOP, thank you so very much. And if you are with us today and are not a member, we'd love for you to consider joining NAAOP. It's easy to do. Just go to our website, NAAOP.org, and right down at the bottom of the homepage, you can join the NAAOP easily. Or if you'd like to, you can actually make a donation to our fellowship. Our 2025 fellowship starts in less than 3 weeks. Annika Berlin will be our fellow in Washington, shadowing Peter Thomas over a 10-week period, and we're really looking forward to her being our 8th fellow. I would like to say that we how proud we are to be partners in the Alliance, working with folks at ABC, Kathy and the Academy, Charity, BOC, Judy, NCOPE, Robin, the Amputee Coalition, Cass, and Ashley, and of course AOPA, Terry Kuffel. And so we want to just let all of you know that every day, each of those organizations and the NAAOP are working to make sure that the lives of those with limb loss and limb difference is better every day. Thank you again for being a part of this webinar, and I'll turn it back over to Nate. Nate?
Thanks so much, George. Okay, to begin, in this presentation, I will focus on the following points. Steps to take when Medicare Advantage plans do not follow Medicare policies, documentation guidelines for coverage of microprocessor knees for K2 patients, and utilizing the newly established L codes for prosthetic devices. And then we'll hear federal legislative and funding updates from Peter Thomas. There's going to be a lot of information presented fairly quickly. The presentation will be available at the website at NAAOP.org sometime tomorrow. If you have any questions throughout the presentation, please ask the chat, and we'll do our best to answer at the end. We'll start by discussing Medicare Advantage reform. In 2024, CMS finalized new regulations to address misuse of prior authorization by MA plans. The next few slides were presented by NAAOP during our webinar in 2023, but the information remains current, and understanding the reforms is one of our best protections from denials. So I'll plan to detail the reforms again. The new rules aim to prevent delays and denials of medically necessary care, issues that have particularly impacted O&P services. Key reforms include requiring PA decisions to align with Medicare coverage criteria, mandating that approved PAs remain valid for the full course of treatment, and ensuring clinical review by appropriately qualified healthcare professionals occurs. For O&P providers and patients, this represents a major policy shift that improves transparency in the PA process strengthens access to medically necessary care, and provides a clearer framework for appealing unfair PA denials. The new rule promotes greater transparency, accountability, and alignment with traditional Medicare standards. Key provisions include approved PAs must remain valid for the entire course of treatment. All PA decisions must be based on Medicare coverage criteria, and clinician-level expertise is required for medical necessity reviews. The rule is seen as a watershed moment, indicating CMS and Congress are serious about enforcing accountability. This is especially significant for high denial areas like O&P, where access barriers have been persistent. The rule requires Medicare Advantage plans to follow national and local coverage determinations. This change eliminates the use of overly restrictive internal policies by MA plans. Prior authorization use is now limited to clinically justified scenarios and prohibited from being repeated for ongoing care once approved. Medical necessity decisions must be based on established clinical guidelines, not vague cost-saving strategies. Stronger guardrails are now in place on utilization management practices and marketing tactics, ensuring they support, not hinder patient care. CMS now mandates that clinicians with relevant expertise review PA denials. This addresses a long-standing issue of unqualified reviewers. The final rule strictly limits how MA plans can apply internal coverage criteria. Internal criteria can only be used if Medicare coverage policies are not fully established, which applies in 3 narrow scenarios. 1, no applicable statutes, regulations, NCDs, or LCDs exist. 2, existing policies allow for flexibility beyond listed indications. And 3, general coverage provisions require supplemental interpretation. Even in these limited cases, MA plans must demonstrate that the service lacks clear clinical benefit and potential harms are outweighed. This sets a higher bar for justifying denials based on internal policies. It strengthens the legal and clinical position of O&P providers in challenging improper denials that deviate from traditional Medicare standards. There are strict standards on how MA plans can develop and apply internal coverage criteria. It ends the use of arbitrary internal guidelines by requiring evidence-based justifications. Internal coverage policies must now be based on credible, peer-reviewed clinical evidence. Unpublished internal data or anecdotal expert opinions are no longer acceptable. Providers are now empowered to demand the evidence behind any denial based on internal criteria and reject justifications that don't meet CMS's evidentiary standards. The rule adds new transparency requirements for MA plans using internal coverage criteria. The burden of proof is now on MA plans to justify their internal policies. MA plans must publicly disclose their internal coverage guidelines, the clinical evidence supporting those guidelines, and a clear rationale for how each policy was developed. If a plan supplements a Medicare provision, it must identify the specific provision being supplemented and show how its criteria provide clinical benefit without causing harm or restricting access. For O&P providers, this is a key enforcement tool. Providers can demand transparency, review and challenge the evidence used in denials, and reject denials that fail to meet CMS's evidentiary and procedural standards. The rule promotes accountability and prevents MA plans from using vague or unpublished policies to deny care. MA plans must now make individualized medical necessity determinations. Determinations cannot rely on algorithms, templates, or rigid software outputs. Plans must assess whether a service is reasonable and necessary by considering the patient's full medical history, functional status, physician input, clinical documentation, and applicable Medicare coverage policies. This is particularly important for O&P, where individualized functional capacity and clinical judgment are critical. Safeguards have been introduced to ensure continuity of care and reduce prior authorization burdens in MA plans. Once a PA is approved, it must remain valid for the entire duration of treatment based on Medicare coverage criteria, the patient's clinical history, and the treating provider's recommendation. This eliminates the need for repeated PA requests for the same service. If a patient switches MA plans or transitions from traditional Medicare, The new plan must honor the existing course of treatment for at least 90 days and do so even if the provider is out of network. For orthotics and prosthetics providers, this means services must be fully honored once approved, and partial authorizations or unjustified re-reviews are not allowed. These reforms offer stronger protection against care disruptions and empower providers to assert patient rights to uninterrupted, clinically guided treatment. Prior authorization can now only be used for 3 specific purposes: confirming a diagnosis or clinical criteria, verifying medical necessity for basic Medicare covered benefits, and assessing clinical appropriateness for supplemental benefits. For O&P providers, this means that these protections reduce the risk of care disruption for patients who receive initial PA approval. It means providers can feel more confident in ordering and delivering services once authorization is obtained, and that any reversal of an approved prior authorization must meet strict legal standards. Plans cannot change their mind arbitrarily or due to internal policy shifts. New oversight requirements apply to utilization management, or policies, including prior authorization in Medicare Advantage plans. All utilization management policies must be reviewed and approved by a dedicated committee. The committee must evaluate all utilization management tools at least annually. These requirements apply the same strict standards used for internal coverage criteria. The reforms close a loophole that allowed outdated or unvetted practices to persist in Medicare Advantage plans. All medical necessity denials by Medicare Advantage plans must now be reviewed by appropriately qualified clinicians. This addresses long-standing issues of denials issued by reviewers without relevant expertise. Denials of prior authorizations or claims must be reviewed by a physician or healthcare professional with clinical experience in the relevant field, knowledge of Medicare coverage criteria, and holding a current unrestricted license. This requirement also applies to peer-to-peer consultations. The rule strengthens the requirement that Medicare Advantage plan denials be reviewed by qualified clinicians, but it does not require same specialty reviewers or specific experience thresholds. CMS allows plans to determine qualifications case by case based on the service and patient's condition. For example, a denial for a prosthetic device does not have to be reviewed by a prosthetist or PM&R physician if the reviewer has appropriate clinical knowledge and understands Medicare policy. For O&P providers, this means you can and should challenge the reviewer's qualification if the denial shows misunderstanding of prosthetic care. You are entitled to request the reviewer's credentials, and you can cite the final rule if the reviewer's expertise appears misaligned with the service being evaluated. Prior authorization versus organization determination. Prior authorization is a pre-service approval requirement used to confirm that services meet coverage and medical necessity criteria. Prior authorization requirements vary by plan, HCPCS code, cost threshold, and provider network status. Some services may even be exempt from PA. Even if prior authorization is not listed, providers must verify plan-specific policies to avoid denials. Organization determinations, on the other hand, are formal coverage decisions made by a Medicare Advantage plan regardless of prior authorization status. Providers can proactively request a determination if coverage is unclear or no PA is required. For example, an O&P provider may request one for a prosthetic component not listed under PA to avoid post-service denials. Why does this matter? Many prosthetic codes are not subject to prior authorization but may still be denied after delivery. Requesting an organization determination is a strategic safeguard. Providers should document all communications with plans regarding PA and organization determinations and keep records of all correspondence and documentation for appeals and audit protection. The Advanced Beneficiary Notice of Non-Coverage is used for traditional Medicare only. It is not valid for Medicare Advantage plans and must not be used by MA plans or their contracted providers, including orthotists and prosthetists. If a provider believes an item or service may not be covered under an MA plan, they should request a prior authorization or submit an organization determination. Improper use of the ABN with MA patients can invalidate patient protections and may result in non-payment for the service. A voluntary pre-service organization determination allows O&P providers or patients to request a formal coverage decision from an MA plan before delivering care, even when prior authorization is not required. It helps determine whether an item is covered and meets medical necessity standards. This can help prevent surprise denials. It's best used when coverage is uncertain, using less common and new technologies, or when you are in out-of-network situations. The appeals process for denied prior authorizations or claims under Medicare Advantage plans differs based on provider status. Contract providers must follow the specific appeals procedures in their plan contract, which may include unique steps, strict deadlines, and limited ability to escalate beyond internal plan review. Non-contracted providers can use a process that mirrors the standard Medicare appeals process, including escalation to an independent review entity or IRE, which currently will be through Maximus for all regions. For O&P providers, it's critical to know your provider status. Are you in or out of network? Understanding your appeal rights in your provider contract helps you respond effectively to denials. Always review your contract to understand your rights and obligations in the appeals process. This slide shows a flowchart copied from cms.gov. The important thing to note here is that for in-network Medicare Advantage providers, all appeal rights are classified as level 1, unless the contract specifically notes an external review process. The level 1 appeal or reconsideration is the first step in challenging a denial by a Medicare Advantage plan. It applies to both contracted and non-contracted providers. Each Medicare Advantage plan has its own internal process, which may involve peer-to-peer reviews and other informal steps before a formal determination. Contracted providers must follow the appeals process outlined in their provider agreement. Non-contracted providers must include a waiver of liability form, or the appeal may be automatically dismissed. Appeals should include a detailed cover letter explaining medical necessity, references to CMS regulations, and clinical documentation and peer-reviewed evidence. The information provided on the in-network appeals process was confirmed through verbal contact with Maximus, where all the IRE appeals are sent, and corroborated through contact with CMS Part C appeals, as evidenced in this email. Now, for non-contracted providers, there's an external Level 2 appeal process. Level 2 appeals are reviewed by the IRE, which is currently Maximus for all jurisdictions. A Level 2 appeal is triggered when a Level 1 reconsideration is denied. Medicare Advantage plans are required to automatically forward denied appeals to the IRE, but in practice, this does not always happen. Providers should proactively contact Maximus to confirm receipt. If not received, resubmit the appeal directly to Maximus following the Level 2 procedures. Non-contracted providers must include a waiver of liability form with every appeal level. Important distinctions. A denied appeal should be automatically forwarded to the IRE by the MA plan. A dismissed appeal is not forwarded. The provider must initiate a dismissal appeal. Some MA plans improperly issue dismissals, often citing missing documentation, even when it has been provided. O&P providers should maintain thorough documentation of fax confirmations, email timestamps, and submission logs. And best practices include tracking appeal deadlines, confirming receipt with the IRE, and ensuring documentation compliance to protect patient access and strengthen appeals. For all Level 2 appeals, the address for the Part C MA IRE for Maximus is included. It's important to note that this is a different address than the address for Maximus that would be used for Part B QIC level reviews for traditional Medicare. Here are several links for additional resources to seek out when preparing and filing an MA plan appeal. The first website shows a history of IRE outcomes and can be useful to see patterns in coverage and information that is helpful in having denials overturned. The last bullet is a link that includes a mechanism to ask questions directly to the Part C appeals team, like the email that was previously referenced. In conclusion, the 2023 CMS final rule has been a transformative shift for orthotic and prosthetic providers, addressing unjustified denials and care delays under Medicare Advantage plans. The reforms are especially critical as MA enrollment exceeds 50% of all Medicare beneficiaries. The rule establishes a new regulatory framework focused on medical necessity, clinical expertise, and transparency. Ongoing challenges remain, including in-network denials with no reporting or oversight available, and plan compliance with new regulation. By understanding and applying the rule, the O&P community can help ensure enforcement of new standards and future policy improvement and protections. Now we'll shift to discussing documentation practices for coverage of MPKs for K2 level users. The final LCD L33787, effective September 1st, 2024, marked a groundbreaking policy shift by expanding Medicare coverage of microprocessor knees to include K2 level beneficiaries. CMS now recognizes that MPKs can reduce fall risk and improve stability for lower functioning prosthetic users. The updated LCD also provides guidance on compatible prosthetic feet that support use of the MPK. For orthotic and prosthetic providers, this means broader access to advanced technology for more patients and a need for clear documentation of fall risk, medical necessity, and functional goals. This is a major policy victory that reinforces the role of innovation in prosthetic care and supports mobility and independence for all users, not just the most active. The updated LCD broadens K2 level access to advanced knee technologies, including MPKs. It places a strong emphasis on comprehensive, individualized clinical documentation. To justify a higher level prosthetic knee, providers must document how the component will improve functional health outcomes, support activities of daily living, and reduce injury risk, especially from falls. Documentation must also show that lower level knee options were considered and ruled out, and why those options are insufficient, but not every alternative must be addressed. Accurate use of billing coding modifiers is essential to ensure claims accuracy and link component selection to the documented K-level and clinical justification. For O&P clinicians, success under this policy requires aligning component selection with clearly documented clinical goals and focusing on patient-specific needs to meet coverage criteria. The takeaway here is that proper justification for an MPK under the new K2 policy must connect the component's clinical benefits directly to the patient's daily function, fall risk, and individualized needs, and must be clearly documented in both prosthetist and physician records. Along with the updates to the LCD, CMS published an updated policy article, A52496, which retains the core definition of K2, but adds clear, practical descriptors to support consistent documentation. A K2 level patient is defined as someone who can ambulate and navigate low-level environmental barriers and is generally a limited community ambulator. To support a K2 classification, documentation should include the patient's ability, with or without assistive devices, to ambulate safely at home, walk on flat outdoor surfaces, negotiate curves, use transportation, climb 1 to 2 stairs, and manage ADA-compliant ramps. These concrete, observable tasks form the functional basis for prescribing advanced technologies like MPKs. Other key clarifications of the policy article include that the use of a wheelchair for longer distances outside the immediate home or property is acceptable. Also, inability to vary cadence except for short durations or with great effort, and infrequent or difficult completion of K3 level tasks is expected. Approval of MPKs for K2 users depends entirely on accurate, individualized documentation of medical necessity. Do not misclassify the patient as K3 to justify the component. Focus on clinical reasons the MPK is essential within the K2 classification. Clearly identify the microprocessor needs K2 specific features, such as enhanced stance control, stumble recovery, and that the component is suitable for K2 users. Align the patient's real-world functional limitations with the clinical benefits of the MPK to build a strong, policy-compliant justification. We should start by confirming K2 status, including ability to ambulate in and outside of the home, and the ability to navigate low-level barriers, possibly with assistive devices or wheelchair use for longer distances. Document relevant medical conditions and comorbidities that affect balance and fall risk. Include history of falls and stumbles, including detail about when and how these occur, and medications that impair motor function. Describe the environmental barriers the patient regularly encounters. Confirm the patient's cognitive readiness and ability to safely use the microprocessor knee, including technology management and battery charging. Make sure to tie the MPK's specific features like stumble recovery and enhanced stance control directly to the patient's real-world safety concerns, mobility limitations, and daily environmental challenges. The justification should be grounded in K2 level functional reality, not an attempt to reclassify the patient as K3. The rationale for selecting the MPK must be linked to the patient's medical conditions and functional limitations, and safety risks such as fall history and excessive energy use with mechanical knees. The key takeaway here is that your documentation should clearly link the selected knee's clinical features to the patient's actual and potential function, while ruling out less advanced alternatives as insufficient, not just less desirable. When documenting medical necessity for an MPK at the K2 level, focus on how the MPK's advanced features mitigate clinical vulnerabilities. Emphasize the MPK's contributions to enhanced safety and stability via adaptive support and safer ambulation over uneven surfaces and inclines. Link the patient's history of falls or balance concerns to improve gait symmetry, stance phase stability, and real-time terrain adaptation provided by the MPK. Highlight the role of stumble recovery for patients with delayed reaction time and impaired balance. Acknowledge that K2 patients may not consistently vary cadence, but MPKs enable brief functional pace adjustments, such as slowing for curbs and accelerating across streets. Use patient-specific examples to show how the MPK addresses functional safety needs that mechanical knees cannot meet. Frame the MPK as clinically essential intervention, not a luxury, by tying its features directly to the patient's environment and health status. Documentation should include referring physician and therapist notes confirming K2 classification, mobility limitations, and medical need for stability and fall prevention, and also thorough records of fall history, near falls, or fear of falling. Fear of falling being a key justification under the updated LCD. Use specific practical examples to show that the MPK is not only beneficial, but medically necessary to support safe, limited community ambulation for a K2 level user. This slide shows some useful outcome measure tools that can be used to help build the case for the need for the higher level of service. These should be performed by the prosthetist in the clinic, but are more impactful when they are also provided by a physical therapist or even the physician. If a trial fitting or demonstration was conducted, include objective outcome measures and subjective patient feedback on safety, comfort, and confidence. Document immeasurable improvements from an MPK trial or compare performance with and without the MPK. Include subjective patient reports to capture quality of life impacts, like I feel more stable when walking across gravel, or I don't have to think about every step, or I can manage the stairs in my building again. Even if the patient's gains are modest, they may still represent clinically significant improvements in fall risk, safety, or ADL performance. This slide shows a few things to focus on when justifying the need for an MPK for the K2 user, such as including real-life examples of abilities, matching real-world function with MPK clinical advantages, and using specific patient-centered language. The main focus should be on current deficits and how the MPK will help to overcome them. For billing procedures, here are some links to the modifier lookup tool for each DME MAC jurisdiction. These will help to make sure that the codes for the MPK have the appropriate modifiers. It's important to note that for region B and C, CGS modifier engine does not recognize K2 as a valid modifier. This is a known issue, and there are efforts to rectify it. Finally, we must ensure individualized, consistent, and policy-aligned documentation. Avoid generic or templated notes. Tailor all statements to the patient's real-world environment and challenges, such as navigating stairs or uneven terrain and performing activities of daily living. All provider reports, including physician, prosthetist, and therapist, should use consistent K-level language and present cohesive clinical reasoning. Use correct coding modifiers. Use current research to support need, including but certainly not limited to these reference studies. Consider incorporating support from manufacturers. Both Ottobock and Oster are strong supporters of this change and are NAAOP members. The documentation should clearly tell the patient's clinical story, showing how the MPK uniquely meets their needs by enhancing safety, improving stability, and supporting limited community ambulation, all within the K2 classification. The final takeaway here is to tell the patient's story through a clinical lens. Show how an MPK bridges the gap between their current limitations and safer, more functional independence. Okay, finally, we'll go over the newly implemented prosthetic L codes. On April 1st, 2025, there was a HCPCS code update that introduced new prosthetic procedure codes for partial hand prostheses and upper and lower limb prostheses. As these codes enter practice, providers must ensure documentation supports medical necessity, functional goals, and component selection rationale, and also monitor DME MAC guidance, Medicare Advantage policy updates, and modifier requirements and emerging coverage criteria. Thanks to significant contributions and advocacy efforts from the Upper Limb Society of the Academy and the O&P Alliance, new and revised HCPCS codes now explicitly apply to partial hand and digital level limb loss, expanding coding and billing options for a historically underserved group. This marks a major expansion of upper limb prosthetic codes, improving access to appropriate technologies and precision in billing and documentation. The changes explicitly recognize the clinical relevance of these technologies for partial hand and finger loss. Of note, CMS has not currently published its payment determinations. Until this happens, reimbursement for the new codes may remain in gap fill status and may require individual consideration by payers. While payment rates are still pending, O&P providers should begin updating documentation and billing systems and monitor CMS and DME MAC announcements for fee schedule updates. This slide shows the newly added partial hand codes. Key clinical and billing notes for these codes are these codes recognize the distinct anatomical and functional needs of individuals with partial hand and digital amputation, allowing more accurate coding and supporting individualized prosthetic care. Be sure to include an anatomical level of amputation and functional goals and documentation. Match code use with specific materials or design features like carbon fiber and acrylic resin, and clearly identify whether the device is intended for use with or without external power. Last Friday, May 2nd, CMS announced a HCPCS Level 2 public meeting, which will be held on June 2nd, 2025. The meeting agenda includes CMS preliminary response to recently submitted coding requests, including requests for additional changes to the partial hand coding set. The comment period for this meeting is now open. Included in the proposed changes are a code to describe an articulating mechanical digit for digits 2 through 4, including full and partial replacement, a code to describe an articulating mechanical thumb, and a code to describe multi-axial mechanism. CMS is also proposing to revise existing code L6028 to read partial hand with or without digits, any amputation level. While doing this, they will also propose to discontinue existing L codes L6000, L6010, and 6020. The new language for L6028 removes the ambiguity of the phrase, including fingers, and along with the proposal to remove the previous base level codes, speaks more directly to the intent that CMS has for the code L6028 as we go forward. They have also proposed to establish a code to describe passive, non-articulating restoration of missing digits. Once again, for these codes, reimbursement has not yet been assigned and will be addressed at a later date. We will be awaiting guidance from the Upper Limb Society and the O&P Alliance on their take on these proposed changes, and we will plan to keep everyone updated as we have more information on these proposed codes. And here you can see deadlines and email submissions for comments for the HCPC coding proposals. Also added in the April HCPC code update, the L7406 describes a user-adjustable socket system for upper limb prosthetic users. This mechanical, non-electronic component allows users to self-adjust socket fit based on residual limb volume changes. It's functionally similar to an L5783 for lower limb users. CMS has not issued specific coverage guidance for upper limb use. Until then, providers should align documentation with the L5783 standards, including daily activity or volume-related fluctuations, impact on function, comfort, and skin health, ability to don and doff the socket, especially due to anatomical characteristics such as a bulbous limb shape, like a wrist disarticulation. Clinicians should describe the functional benefits of L7406, such as increased wear time, greater independence in ADLs, improved ease of donning and doffing, and fewer clinic visits for adjustments. Providers should confirm that the patient has cognitive ability to use the system and maintain socket fit, and the physical ability to use the system safely. Until formal CMS guidance is available, best practice includes referencing lower limb guidance for L5783 and explaining the parallel clinical rationale for upper limb use. For lower limb prostheses, L5827 is a new base level knee code used to describe powered knee components. It replaces previous coding guidance of L5828, 5845, and 5848 for the Oser Power Knee, Willowwood Intui, and Bionic M BioLeg. From a reimbursement perspective, L5827 is priced equivalently to the sum of the 5828, 45, and 48. While CMS has not issued explicit coverage criteria for L5827, it is expected to align with existing MPK codes that require documentation that supports a K3 functional level or higher, remembering that the powered knee components are not indicated for K2 users, and demonstrating clinical benefits. When billing, use 5827 alone for the applicable powered knee systems. Inclusion of the 5845 and 5848 will be considered unbundling. Okay, I know that was a lot of information in a short amount of time, so thanks for hanging in there, everyone. Now we're going to transition to the federal legislative and funding updates presented by Peter Thomas, General Counsel for NAAOP.
Thanks so very much, Nate. Great job in getting through a lot of material in a very concise manner. I'm going to talk just a little bit about some of the issues very much in play in Washington, D.C., and try to give you a little bit of an update as to where things stand and what NAAOP is doing to try to impact some of these policies, both individually as an organization and in conjunction with our O&P Alliance partners. That includes the Academy, AOPA, BOC, and ABC. And of course, we work closely with the Amputee Coalition and the Research Foundation, the NAAOP, and other organizations as well. So let me start first with some big picture budget issues. The budget being discussed in Washington is headed towards a reconciliation bill. A couple of weeks ago, the Senate and the House passed the exact same budget bill, which calls for a reduction of only $4 billion over 10 years. But that is a hidden number. That's what the Senate bill wound up coming out at. The House bill called for a $1.5 trillion reduction in funding for various programs and assigned to the Energy and Commerce Committee, removing from the or eliminating from the budget, reducing spending by $880 billion over 10 years. The Energy and Commerce Committee has jurisdiction over commerce programs that don't generate a whole lot of revenue, and Medicaid. They also share jurisdiction with the Ways and Means Committee on Medicare. Medicaid is being targeted for a gigantic cut in funding. Whether they'll be able to get that through the House, because there's only 3 votes that Republicans have, if they lose more than that, the bill won't go forward. So it's a very delicate balancing act to try to get a budget bill of that magnitude across the finish line. That's just the spending reductions. The main purpose of the reconciliation bill is to address a number of the priorities of the new Trump administration, including extending the current tax cuts that he was responsible for spearheading during his first term. That should cost somewhere around $4 to $4.5 trillion, which is a gigantic price tag over a 10-year period, as well as a number of immigration policies and other kinds of big ticket items that the Trump administration would like to see passed. That requires some offsets in spending, and that's where the Medicaid spending cuts may come in. I say may because there's at least 12 Republicans in the House, moderate Republicans, who have already sent a signal to the Speaker Johnson, that they will not vote for a bill that's materially cuts Medicaid, especially vulnerable populations under Medicaid. There are also certain factions in the Freedom Caucus and on the fiscal hawks who want to demand that they cut at least $880 billion from Medicaid and other programs, totaling about $1.5 trillion in spending reductions over a 10-year period. In the Senate, there's not nearly the appetite to cut Medicaid to that extent. In fact, I just heard yesterday, that the chairman of the Senate Finance Committee, Senator Crapo, says that he is on the phone with President Trump 2 or 3 times a week and has expressed to him that he does not think that the Senate can pass a bill that cuts Medicaid to that extent. And of course, all along, the president has vowed that Medicare and Social Security would not be included in the reconciliation bill. The reconciliation bill allows the Senate to pass the bill with only 51 votes, and they have 53 Republicans in the Senate. Most bills are subject to the filibuster, which would require a vote of 60 senators to get through a procedural vote and move on to the merits of any given bill. So you really have to have bipartisan support on most bills to bring them to a vote in the Senate. So will Medicaid be cut or won't it? We don't quite really know now. That's what the Congress is grappling with this week. They'll continue to grapple with it next week and in the weeks and months to come. They were supposed to mark up the bill last week, and that was postponed. So that is not a harbinger of quick success. But this is a major policy objective, and frankly, there's a lot of moving parts to it. We really just don't know how it's going to come out in the end, but they are working intently to try to move forward on it. From an O&P perspective, our concern, of course, is that if they drastically cut Medicaid, there will be patient populations that will no longer be able to get access to O&P care. And many of those populations came into the Medicaid program through the expanded program under the Affordable Care Act. Some of them are under the original Medicaid program that serves people with disabilities, frail elderly, children, and others with very, very low incomes. And it's really a question as to whether individuals who currently rely on the Medicaid program to get access to O&P care will be able to access that care, or whether they'll just show up on your doorstep and say, my leg broke, you got to help me, with no payer. That's a big concern of ours, and we'll be monitoring that very closely. There are other major changes on the horizon in terms of funding levels for the federal programs. The Trump administration produced what they called a skinny budget last Friday. They will come out with a much more detailed budget. It's expected on the 19th of May. And it's not clear how that budget is going to come out. Most years, the Congress just looks at that budget as one document, as something that starts the process. It lays out the president's priorities in any given spending year. But this year, it's taking on a bit of a different form because DOGE, the Department of Government Efficiency, has been shuttering federal offices, firing staff, chipping the letters off of various buildings around Washington, really taking fairly proactive and aggressive moves to move forward with how they envision the federal workforce and the federal government behaving and operating going forward without congressional approval. There's been numerous lawsuits. There have been some lawsuits that have been successful in restoring funding and restoring parts of the federal workforce. And in some instances, DOGE has made mistakes and has rehired people back. But that will continue for at least another year and 2 months before DOGE lapses in July of 2026. Even though Elon Musk has separated as leading DOGE, the DOGE effort continues. So what does that mean for us? It means that research programs at the NIH, O&P research in particular, O&P programs and research programs at NIDLR, which is the National Institute on Disability, Independent Living, and Rehabilitation Research, that is housed within the Administration for Community Living, as well as programs like the Limb Loss Information Center, the Spinal Cord Injury Resource Center, and other programs like that mean a lot to our populations, are at risk of being defunded. There's every indication that the Trump administration, if they had their druthers, would no longer have those programs being funded. They would zero fund them. That's 72% of the Amputee Coalition's Limb Loss Information Center program, which covers a variety of different activities that the Amputee Coalition supports. So we're very alarmed about that. We're doing everything we can to get that turned around. Obviously, the Amputee Coalition is taking the lead on that, but we are trying to be as supportive as we can be to try to get that funding not only flowing in fiscal year 2025, which ends at the end of September, but lining up their budget for next year as well, fiscal year 2026. I'll say one more thing about research, and that is that the Department of Defense has a program called the CDMRP, and under that, which that stands for, by the way, Congressionally Directed Medical Research Program. Underneath that program is something called OPORP, difficult name, but it stands for Orthotic and Prosthetics Outcomes Research Program. That's been funded since 2014 at about an average of $15 million a year. It was defunded. It was no longer funded in fiscal year 2024. Last year, the O&P Alliance and NAAOP, as part of that alliance, took it upon themselves to try to fight for funding to restore that O&P outcomes research. We were not successful in getting a $15 million set aside, as in previous years, but there was some very strong report language that was included in the DoD bill that would have allowed O&P research to been authorized under the peer-reviewed account under the DoD. This is an account that used to be $370 million. This current fiscal year, it was knocked down to $150 million, but that's still 10 times the amount of O&P research that was being funded previously under the same basic account. We think our researchers can compete with anyone. And frankly, we've built up a cadre of very strong O&P outcomes researchers over the last 10-year period, and we think we'll compete well in that environment. It was great news to us to learn that the report language that had been included in the FY 2025 Senate bill last summer did in fact survive the continuing resolution, which extends through the end of September. Normally the report language falls away when you pass a continuing resolution, but in this instance, they did accommodate for that, and they ultimately kept that language intact. What does that all mean? It means that O&P researchers will be able to receive funds if they compete and win on high-scoring grants through the DoD program this year. We'll be working and have been working both independently as NAAOP and through the O&P Alliance to try to get that funding restored and in fact potentially increased in 2026. There's a number of legislative bills that I wanted to quickly touch on. One is the Medicare O&P Patient-Centered Care Act that AOPA has taken the lead on, but that NAAOP has played a significant role on this year in manipulating and modifying some of the language to make sure that it's as efficient and concise as possible. We do expect that bill to be introduced very shortly. We've got good bipartisan support in both the House and Senate side. There's another bill called the VA Sport Act. This would mandate activity-specific prosthetic coverage under the VA. The VA doesn't support the bill because they feel as though they already do that, but we don't feel as though it's consistent across the country, and we're supporting that legislation. We'll see if that takes root and gains traction this year. There's also the Mobility Means Freedom Tax Credit Act, which was recently introduced by Congressman Cohen, a Democrat from Tennessee. He was not able to get a Republican co-sponsor, which does not bode particularly well for that bill passing, but he's seeking to have it included in the reconciliation bill. What it would do is provide beneficiaries, actually anyone in the country, with a 50% refundable tax credit for out-of-pocket expenses related to mobility devices, prosthetics, orthotics. We were actually contacted by Congressman Cohen and asked to support the bill, but it did not include prosthetic limbs. And we were able to get him to include that in the final bill when it was introduced. Again, we don't have high hopes that the bill will pass, but we are doing everything we can to try to make sure that it gets as far as it can possibly go for the benefit of people with limb loss and limb difference. And finally, let me just mention something about tariffs. I've heard a lot about tariffs in the recent past. There's a lot of concern out there. One of the biggest concern with respect to O&P is that if you do have to, if tariffs are in fact imposed on prosthetics and orthotics, there's no other way to pass this on to the beneficiary or to the end user the way the regular market works, because Medicare and other payers are not going to be increasing their fee schedules to essentially cover the cost of the increased tariffs on depending on what country it comes from, could be anywhere between 10 and 125 or 145%. That's a non-starter. It means that providers and practitioners will be pinched. The good news is that the Nairobi Protocol, which is something that's been on the books for 3 or 4 decades, considers most prosthetics and orthotics to be exempt from tariffs. They in fact pay zero duty upon entering the country. That is similar to the treatment, the tariff treatment of other mobility devices and things that serve the needs of people with disabilities. It doesn't apply to everything. There are some exceptions, but by and large, the tariffs don't typically apply to O&P, and that's exceptional news as we for the field and of course for anyone involved in the provision and the receipt of O&P care. and we'll continue to update NAAOP membership with new developments as they occur. I'll stop there and see if there's any questions. Nate?
Great, thanks, Peter. I do see that we did have a couple questions that I'll bring up here. Two people asked if they'd be able to get a hard copy of the slides. So it would be my intent that both the webinar and a hard copy of the presentation are both put online. As I said, I think this should, hopefully it's helpful as a resource to use later on. The next question is from Brooke McKee, and it asks if a K2 is not a recognized modifier for regions B and C, does this mean we are unable to bill for K3 as the K2 currently, or is the way to do this for these regions? The current recommendation would be to still use the K2 modifier and then just follow through the appeal process, even though that's an onerous process right now. But it's still using the K3 modifier in place of the K2 modifier would be inappropriate and would not be recommended. And there's the last question here I see is from Nikki Grace, and it asks, does Nairobi Protocol apply to materials that go into making prosthetics domestically? So does it go into the materials, Peter?
Well, anything made domestically would not incur a tariff. So that's in fact one of the motives of the Trump administration in imposing tariffs in the first place, and that is to bring manufacturing back onto the shores of the United States. But materials is one of those exceptions to O&P. Most parts, most accessories are covered under the Nairobi Protocol, meaning zero tariff. But materials don't necessarily get the same protection. And so raw materials that are used in the fabrication of prosthetics have a tougher time getting duty-free treatment. But of course, there are companies that have gone forward over the course of the years. There's quite a bit of case law with the Customs Office on what is considered duty-free and what is not in the O&P field. But as a general rule, most fully constructed devices, most components, most parts, and most accessories are in fact duty-free. There are ways to apply for an explicit exemption to clarify whether your particular product is duty-free. And there is some question about there's most definitely some varying treatment of materials. And if you can link the materials as closely as you can to being used in prosthetics and orthotics and not necessarily in other areas, you have a better chance of getting zero tariffs imposed. But let me provide a big caveat. Tariffs have not been something that have really impacted the healthcare field for a long time. They were really first brought up under the first Trump administration, and now everyone's asking questions about them. I am not an international trade lawyer, and that is the area of law that really determines this. I have done some significant research on this issue, and I'm finding more and more comfort in the research that I've done and the Nairobi Protocol and its case law that follows, that most of O&P is going to be okay under a tariff scheme. There will be exceptions. There will be requirements for some companies to go to the Customs Office and to appeal for direct exemptions from the tariffs. But I would not send a signal for the field to panic at this point, because there are some pretty well established exceptions to the tariffs for O&P care.
Great, thank you, Peter. Well, I guess that about wraps up our time. So I'd like to take a minute just to thank everyone who attended, members and non-members both. Non-members, as I said, on NAAOP.org, very easy to join if you find that this content was helpful. I'd also like to say thank you to Paul Prusakowski for all the behind-the-scenes support. Thank you, everyone, and have a great day.
Thank you. Bye now.